Hello everyone, this is Jen, and with me I have Gillian Ray-Barruel, who is from the Avatar Group and Griffith University, who's going to talk about intravenous access devices and infections. Thanks, Gillian.
Thanks, Jen. Hello everybody. So I'm Gillian, and today we're going to talk about intravenous access devices and infections. So we have several learning objectives for the session. Firstly, we're going to identify 4 pathways of intravenous device bloodstream infection, BSI. I'm going to talk to you about the significance of biofilm, phlebitis, thrombophlebitis, and IV access device infection, including CLABSI and CRBSI. Describe the risk factors for IVAD-associated infection. Identify the best practice for PIVC insertion. Explain the bundle approach to infection prevention. Describe nursing interventions to reduce CLABSI, and identify best practice strategies to prevent IV-associated infection. So let's begin with a quick overview of the numbers of IV devices used. 90% of IVs are peripheral devices, and globally more than 1 billion peripheral IVs are used each year. Most of the focus of infection control has been on central vascular access devices, but we now realise that peripheral devices also cause bloodstream infections, and because many more peripheral devices are used, it's important to understand their role in causing infection. This picture demonstrates the 4 possible pathways for developing a bloodstream infection. The first possible pathway is migration of microbes down the catheter tract, that is, through the wound created to insert the catheter. These microbes may be from the patient's skin, contaminated disinfectant, or healthcare workers' hands. The process may happen on insertion if the catheter is contaminated and then introduced into the patient, or via microbial migration at any time while the catheter is in situ. The insertion of an IV device provides a potential portal of entry for bacteria to cross from the unsterile external environment to the normally sterile blood. The second route is via the catheter hub, which can become contaminated by healthcare workers or patient skin flora during connection of fluids, medication administration, or during extraction of blood. The third route is for catheters to be contaminated directly by bacteria circulating in the bloodstream. That is, the patient has an existing bloodstream infection and microbes are able to attach to the catheter as they pass by the device. And the fourth pathway is that of contaminated infusate, which may occur at the manufacturing stage or during manipulation by healthcare workers. Biofilm is a matrix of fluid and cells forming on the surface of any invasive device, and this creates an environment for microbial growth. So bacteria attach to the biofilm and multiply, and the longer the catheter remains in the body, the greater the chance that the biofilm will embolize, break off, and go into the bloodstream and cause an infection. The most frequently isolated bacteria from IV devices are coagulase-negative staphylococci and Staphylococcus aureus. And these bacteria are usually from the skin flora of the patient or the hands of healthcare workers. But when they reach the patient's tissues and organs via the blood, they can cause serious infections and high mortality rates. The next most common pathogens for IV-related infections are gram-negative bacilli, and these microorganisms are generally acquired from the hospital environment, for example, Enterobacter. Fungi, such as Candida species, usually come from the hands of healthcare personnel, contaminated infusions, or parenteral nutrition, and these are also implicated in catheter-related infections. So phlebitis is inflammation of the vein, and this can be mechanical, chemical, or infective. Mechanical phlebitis is caused when the catheter, the hard surface of the catheter, irritates the vein walls. Chemical is irritation of the vein by the infusates and medications, and infective is inflammation caused by a response to microorganisms circulating in the blood. Irritation of the vessel walls by this stiff catheter material, infusates, or bacterial colonization then damages the endothelium, and this process provokes inflammation of the vessel wall with fibrin deposition and thrombus formation. So thrombophlebitis is phlebitis combined with thrombus formation. And this is a frequent complication of peripheral IVs, and reported rates range from 2 to 80%. And this remarkable variation in reported phlebitis rates is due to distinct study settings and a lack of internationally accepted phlebitis definitions. But basically, the clinical signs of phlebitis include redness, swelling, tenderness, pain, warmth, palpable cord, or purulent discharge. Now, central line-associated bloodstream infection, or CLABSI, is identified when a patient with a central venous catheter has a positive blood culture result obtained from a peripheral vein and clinical manifestations of infection, so fever, chills, and or hypotension, and no apparent source for the bloodstream infection except the catheter. So central line CLABSI is really, you're assuming it's the catheter causing the infection. Whereas catheter-related bloodstream infection, to say for sure that a bloodstream infection is definitely caused by the central venous catheter, say, then one of the following should be present. A positive culture result, so 15 colony-forming units per catheter segment, and the same organism is isolated from the catheter and a peripheral blood culture, or a differential time to positivity. And this means that the growth in the blood culture obtained through the catheter hub becomes positive at least 2 hours earlier than a culture of blood drawn from the peripheral access at the same time. Calculating catheter-associated infection rates, this is important because knowing your hospital's catheter-associated infection rate can provide a benchmark to measure your progress in reducing catheter-associated bloodstream infection. So this is a simple calculation: the number of catheter-associated infections divided by the total number of catheter days per patient population times 1,000, and you report this as the number of catheter-associated infections per 1,000 catheter days. The significance of catheter-associated bloodstream infection: this is a very significant infection because the mortality is between 12 and 25%. It's a very expensive occurrence, with reports up to $56,000 per event. And this is because of staff time, hospital bed days, diagnostics, treatments, ICU days, etc. We also know that 12% of Staph aureus bacteremias come from peripheral cannulas. And clearly this is this has an impact on patient experience, pain, anxiety, treatment delays, increased lengths of stay, and eventually venous depletion from having too many needle sticks. So it's a very significant event. Now, risk factors for catheter infection. The first one is dwell time. We know that this is one of the major risks of peripheral intravenous catheter infection. However, we also know that routine removal of catheters does not reduce risk. This is because it is the overall exposure to IV use that increases risk. So as the number of catheter days in total increases, the risk of bloodstream infection increases. Poor securement is a problem because when IVs are not properly secured, micromotion within the blood vessel can cause vessel trauma and migration of organisms along the catheter and into the bloodstream, leading to CRBSI. And if the catheter is not stabilised properly, this can lead to catheter dislodgement, necessitating a replacement catheter to be inserted. And consequently, repeated catheterizations increase the chance for introduction of microorganisms, and it also leads to reduced vessel integrity. So every time you stick the patient for a new IV, you are increasing the risk of infection. Healthcare risk factors. We know that insertion and maintenance of PIVCs by untrained personnel has long been associated with a higher risk of bloodstream infection. Inadequate skin antisepsis technique or insufficient drying time prior to insertion are also risk factors for infection. The recommended method of skin antisepsis is a back and forth scrubbing motion with 2% chlorhexidine gluconate and 70% isopropyl alcohol, or povidone iodine in alcohol for patients with a sensitivity to chlorhexidine. Then allow the site to air dry prior to the insertion of a catheter. Inadequate decontamination of needleless connectors is a big healthcare risk factor. Needleless connectors were introduced into clinical practice to minimise the risk of needle stick injury. They're used on almost all intravascular devices nowadays, and they provide an easy access for infusion connection. However, colonisation of needleless connectors is a major cause of post-insertion catheter-related infections. Many guidelines recommend scrubbing the needleless connector hub to minimise the risk of microbial contamination. Improper disinfection of needleless connectors can result in contamination of the internal lumen of the catheter with bacteria, resulting in the formation of biofilm and potential for bloodstream infection. However, unfortunately, the best antiseptic and technique for disinfecting needleless connectors is still being investigated. And documentation being inaccurate or absent from the medical record is a problem because it makes it difficult to track the infection back to the catheter, and catheters get missed when they're not documented. Dressing risk factors. It's important to remember that the catheter insertion site is a wound. Therefore, to prevent infection, the dressing covering the site should keep it clean, dry and intact and offer protection from external contamination. A sterile gauze and tape dressing is suitable for oozing sites, but it needs to be changed every 48 hours or more frequently. These dressings are comfortable for patients because they keep the wound dry by absorbing exudate from the insertion site, but they don't provide a waterproof barrier, and once wet, they offer an environment suitable for bacterial growth. They also don't prevent catheter movement, and they don't allow visual inspection of the site, so they're best used for short term. Transparent semi-permeable dressings can remain in place up to 7 days. These have evolved over time to offer greater vapor permeability, which increases the rate of evaporation of fluid from the insertion site, keeping the site dry and reducing the risk of infection. And these also allow for visual inspection of the insertion site, making it easier to identify early signs of infection. Over the past few years, there have been some dressing innovations. Securement dressings and devices aim to prevent micromotion and prevent dislodgement. We're also seeing tissue adhesive or skin glue, which has shown some promise in reducing catheter dislodgement. And especially for central lines now, chlorhexidine discs and dressings can reduce skin colonization around the insertion site, which has been identified as the leading cause of both local and systemic infection. However, chlorhexidine discs and dressings are not suitable for neonates or people with chlorhexidine sensitivity. There's a lot more work going on in this area. So we do know some simple strategies for PIV insertion that will promote best practice and reduce the risk of bloodstream infection. Clearly, hand hygiene is essential, and inadequate hand hygiene by healthcare workers is a direct risk factor for infection. Appropriate disinfection of hands before a catheter gets inserted or before donning gloves significantly reduces the incidence of infection. Hand hygiene should be carried out before and after any contact with the PIVC or insertion site, and this includes decontaminating hands using an alcohol-based hand rub or washing with liquid soap and water if the hands are soiled or contaminated with blood or body fluids. To further minimise risk, practitioners should avoid wearing wristwatches, stoned rings, long sleeves and long fingernails, and gloves should be worn when performing cannulation. 2% chlorhexidine and 70% alcohol prep is recommended, but this has to be allowed to dry before insertion and accessing the cannula. The drying time is essential because this is when the microorganisms are killed. And studies have repeatedly shown skin antisepsis before insertion of a catheter helps prevent CRBSI. Povidone, iodine and alcohol can be used for patients who are sensitive to chlorhexidine. Aseptic insertion technique is essential, so after the area has been cleaned and allowed to dry, it must not be touched again unless wearing sterile gloves. The forearm is the best site for reducing movement of a peripheral catheter. Try to avoid the wrist and antecubital fossa if possible for longer-term IVs due to micromotion of the catheter in areas that bend. Trained inserters plus or minus ultrasound for difficult IVs can reduce vessel trauma and chance of thrombophlebitis. And intravenous teams are definitely associated with better PIVC outcomes. A bundled approach to IV catheter management has been repeatedly proven to standardise care and improve patient outcomes. A bundle is a small set of evidence-based interventions for a defined patient population and care setting that, when implemented together, result in significantly better outcomes than when implemented individually. This means that bundles are designed to be used in their entirety. The following is a central line insertion bundle recommended by the Institute for Healthcare Improvement. Hand hygiene, maximal barrier precautions, chlorhexidine skin antisepsis, optimal site selection, avoiding the femoral if possible, and daily review of the necessity for lines and prompt removal of unneeded lines. So all 5 of these are equally important in the bundle. When implementing a bundle of evidence-based practices, you also need to educate staff on all the elements of the bundle, implement a checklist to ensure compliance with the bundle, and empower nurses to speak up if they witness any breach of best practice. It's also important to provide feedback on infection rates to staff and hold monthly meetings to track progress and keep staff engaged with the quest for preventing infection. Most complications associated with the use of IV catheters are preventable. Here are some simple strategies that have been shown to reduce or prevent infection. Education for staff and patients. This is a key element in reducing catheter-related infection. Evidence-based cannulation training, theory and simulated practice, combined with a subsequent period of supervised training in the workplace, are great learning procedures to help inexperienced novices become fully competent. Research has shown that intensive education programs can improve overall cannula care, leading to significantly decreased incidence of bloodstream infection. Furthermore, staff should educate patients to look out for early signs of infection at the cannula site to help early detection. And if a patient is going home with an IV access device, the patient and their carer should be taught techniques to prevent infection before discharge from hospital. Clearly, hand hygiene, as we discussed, a sterile adherent dressing, securement of lines to prevent micromotion of cannula, aseptic non-touch technique of key parts when administering fluids or medications, and disinfecting needleless connectors. These are all important strategies. Documentation of each catheter insertion using an intravenous device care plan could help reduce the incidence of catheter-related infection. And evidence indicates that cannula insertion is often not documented, which leads to IVs being missed or forgotten about. Documenting the device insertion and ongoing assessment encourages ongoing cannula care and prompts removal if the catheter is not needed. Removing unneeded lines is essential. Prevalence surveys have shown that up to 25% of peripheral lines are left in place when not being used. This is a direct risk for infection. Routine replacement of peripheral lines is not necessary if the PIVC is working and the patient has no adverse symptoms. Routine replacement of PVCs every 3 to 4 days was standard practice in many hospitals in the belief that the strategy could help prevent catheter-related infections. Early studies suggested that restricting the duration of PIVCs might prevent infection. However, results from recent studies have demonstrated that clinically indicated replacement of catheters has equal infection risk as routine replacement. Clinically indicated removal requires frequent close monitoring of the insertion site with timely treatment cessation and prompt removal once the treatment is complete, and continued monitoring for complications, including suspicion of infection. We do know patients can develop phlebitis up to 48 hours after a peripheral cannula has been taken out, so it's important to keep assessing. Clinically indicated replacement has several advantages over routine replacement, such as avoidance of unnecessary repeated skin punctures, potentially non-aseptic insertions, and reduced health costs. Finally, mandatory surveillance and routine audits. Performance feedback is another important strategy in reducing infection. There is unequivocal evidence that performance feedback contributes to improved professional practices and better healthcare outcomes. In conclusion, intravenous access devices are a portal directly to a patient's bloodstream, and therefore they are associated with a high risk of bloodstream infection. We hope this presentation has provided you with some useful strategies for identifying infection risks and implementing strategies to reduce those risks. For further information, please visit our website. Thank you.
That's fantastic. Thank you.